So globally, it's the same thing. We really have a great opportunity to use navigation as a tool to get patients across the cancer continuum to the resources they need. I'm just going to skip a few of these slides for the sake of time. So just to talk about a few of our programs, and not to harp on our programs, because I think, again, for us, it's really about building interconnected networks. So we have a large capacity development program called Beacon for patient navigation, and it's really about the local partner developing the resources that fit their context. We just published our work on Kenya, and we're able to show that patients were educated and completed their treatment. We don't have outcome data yet, but we will eventually. But we know those are the first steps. But it's really about the local partner developing the sustainable navigation within their setting. So we provide support for that. We now have about 40 community partners in 25 countries and really want to build a global movement around navigation. Again, really thinking about the non-medical pieces that are key for helping patients. And then the second program we're developing is a more nationalized system within 3 countries called SPARK, Kenya, Indonesia, and Nigeria, to develop a more national navigation strategy to create policy change and sustainable practice change. And again, those countries could then be a model for other countries globally. And then I just wanted to talk a little bit about some of the thoughts we've had about building collaborative networks. We just launched, we had our kickoff meeting at ASCO for our Global Alliance for Cancer Patient Navigation. So again, really just highlighting all the things that are needed to support patients outside of the treatment. So we're really hoping with this alliance, which has now more than 50 organizations from 25 countries, all 6 continents represented, both high-income and low-middle-income countries represented, that we can really start to create a framework for policy change so that we can really support patients in all settings. We heard from our partners in Australia, New Zealand, Europe, as well as all the LMICs that we need to do better. And similarly, again, in thinking about partnering, we have lots of resources. Many organizations have lots of resources. We're launching the ACS Global Academy later this year. It's really to connect patients to resources and partners to resources. Beyond giving a webinar or a talk, how do you move from learning to action? How do you create sustainable implementation? And so our academy is really that, is we want to connect our partners to the resources they need. Beyond that webinar, it's really toolkits that allow you to make sustainable, implementable change and also measure impact over time. Without that, we're not going to really move the needle at all. And again, we're really inviting all partners to come into these efforts. It's not something that we need to lead, but we really want to support all partners. So I just want to leave you again with those 2 thoughts, the collective impact model, and now also I want to just give a brief tribute to the Binding Cancer Moonshot. So for me, starting in 2007, I was able to participate in the US-India Cancer Dialogue in 2024. And again, the message of the Cancer Moonshot, it's really more of a ground shot, it should be called a ground shot, but it's really about partnerships, right? Out of this meeting came discussions about the Quad, so US, India, Australia, and Japan working together. So I think that was really the key takeaway. But we did also stress at this meeting that we have to focus on that 90% of patients that aren't getting the supportive care they need or the palliative care they need. And yes, innovative technologies are important, but we really need to think about that as a first step. So I just wanted to leave you with that. So we need advocacy around shared goals, really keeping the patient and the caregiver at the center. And then also, whenever you're implementing any project, I think at the outset, rather than later on, really start to think about where are there opportunities for collaboration. And also that really fits well with the UN Sustainable Development Goal for the year, partnerships for the goals. Thank you very much.
Thank you very much, and it's great presentations and really interesting projects being done by the ACS here, which really show the importance of collaboration, networking, partnerships, which is really the theme of today. Any questions? Gustavo?
From for instance, I'm thinking Latin America, for instance, 2,000 children die in Brazil a year because, even if you have drugs, they don't test if the drug is working with a simple blood test that can be done with a point-of-care device that costs $600. Yeah, and I guess, as you mentioned, the problem is simple technology that can be used to help, many children in this case. are not being used, and it's not because they are not a global collaboration as you mentioned to do the project. You can see 300 projects going around and no one going to no place. Therefore, I guess what I would like to see how the American Cancer Society can help other cancer societies from other countries to execute those type of things. The navigation, for instance, people in Brazil, for instance, they have cancer and they think it's a death sentence, you know, because cancer is increasing because of lack of prevention and so on. Therefore, I guess to work on how to translate this to all the other countries is
Right.
critical.
Yeah, and that's a key point. So we have a network called the Global Relay for Life, but it's been just about fundraising and development across these 35 countries. So when I started, I was like, well, we have this amazing wealth of countries, high-income, low-middle-income countries. Why are we not doing unified mission work, right, to solve these issues? Like, we have a great model with the ACS in the United States. Other countries want to emulate that. And a lot of that work happens at the ground level with volunteers, advocacy at the ground level, and then you start to make system change, right? And that occurs over many, many years. And so that is really the goal now, is can we use that network of country, these pan-cancer organizations, to start to, first, developing now this year, a storytelling project with survivors, to really start to think about change the narrative around cancer. There's another organization called Survivor, which is specifically looking at this for cervical cancer survivors. So I think that is a key opportunity to start to bring up issues that we can then bring to the forefront across the globe.
And educate the governments, I would say, because the main problem is supporting the lung cancer.
Exactly right. That's policymakers at the end of the day. I think we have to show a lot of the interventions are not expensive, right?
Yeah.
So supportive care decreases hospitalizations, ED visits. Navigation decreases the resources. In the end, we have to show more data though, because that's really going to be key.
They would have spent less money or what they're spending now.
Exactly. And that's a big part of the reason that costs have increased in the United States. It's become more medicalized, but all the other services that are cheap, again, I think it's a good follow-up to what Dr. Booth presented, those things have been marginalized, and that we have to refocus that.
Any other questions?
May I ask a question? It's wonderful to see the organization. I represent Bangladesh, and I saw that American Cancer Society is having partnership with many. Although we are having a charter that's good for our cancer screening with that capitalist. Do you have any plans to come to Bangladesh? Because
Yeah, definitely.
we're in need of organizations like you to eliminate cancer for Bangladesh.
Yeah, well, I would love to connect, and then we are supporting work in HPV vaccination in India and hoping to help Bangladesh with the rollout upcoming. So that's some of our
Very
plans.
exciting.
But happy to connect.
Okay. Well, thank
Thank
you
you.
very much. Thank you. Thank you. And our final speaker in this session, before we get to our discussants, Professor Hedi Horecek from Sloan Kettering, very famous nuclear medicine, very famous person, everyone knows him. Long-term collaborator and friend in the Lancet Oncology, and the lead on a number of our commissions. And Hedi's going to be talking today about how some of these commissions and the work we've done in those has all come together into a new UN resolution. So Hedi, over to you.
Thank you very much, David. As we talk about collaborations and networks, I think looking at the success of our resolution is really an example what collaboration and networks can do. So it was actually less than 2 weeks ago in Geneva, the resolution on medical imaging capacity was approved. And it started with all of us caring that cancer and our planet is a death by scaling up diagnostics Thank you for mentioning diagnostics more than one. It is a cornerstone of healthcare. Treatment and quality of care. And then we really need to harness and computer analytics. Global cancer disparity, 35 million, 77% increase, but out of that, 142% is going on incidence, is going to be in the low and middle income countries. As reported at the London Cancer Week a few years ago, in low middle income countries, cancer mortality is surpassing mortality of HIV/AIDS. Malaria can make a difference. Those data are from 11 most common cancers, 2030, 76 million treatment, just treatment and quality of care, to 5 point. We can avert 9.5 million or 12 point. So globally, we can really save a maybe 35.7, and we know that the higher in the low middle income country because of the lack to diagnostics and treatment. Investment, because we also have to speak to policymakers. So for every dollar invested globally, we will save $12.45. In Africa, that almost doubles. And I think this was one of the reasons, the data we looked at, where we can make a difference. And we can also speak to the policymakers. I like to say, if you choose to ignore today's concerns, you will be faced to confront tomorrow's crisis. And the crisis is already looming, and we are so global. What happens in any part of the world affects all of us. So therefore, in 2023, we did have a dream. We had a dream that one way to impact and improve that imaging is available everywhere is really through resolution. Because those World Health Assembly resolution impact on investment in infrastructure, on education, and what really I care a lot, patient access. Because then the ministry and policymakers are going to include imaging and reimburse right now, even if there is a CT scanner. Patient has symptoms of stroke, they don't have access or they cannot pay for it. The resolution is based on 3 Lancet oncologies, imaging and nuclear medicine, cancer in sub-Saharan Africa, and the radiotherapy and theranostics. We put together a team from all lead authors from those 3 Lancet publications, and then added a few other because we really wanted diversity and make sure that we have representatives from each continent. I really want to say thank you to Will. Will was always there for us. Thank you very much. And it wasn't easy, but we never ever gave up. And David, thank you to you, truly thank you. This resolution from day one was supported by Lancet Oncology. We designed a website strengthening medical imaging capacity, and once again supported by the Lancet Oncology, who allowed us to put their logo on our website. Well, one big problem was finding you can have all the dreams you want in academia, but to have the best resolution pass, you have to have a member state that really runs with the resolution and works with WHO. And at this moment, it was not easy. I can tell you, we had quite a few candidates and didn't work out. So at the very last minute, Will and Jennifer then came to rescue, and with Cameroon agreed to sponsor the resolution. It was a wonderful day when they finally sent a letter and said yes. A resolution was accepted by WHO. It's not just that the country has to propose, WHO has to accept it based on the data that is needed. And then we had, during the discussions, there were a number of member states that actually truly agreed and agreed to co-sponsor. They are Brazil, Armenia, Burkina Faso, Colombia, Thailand, and China. We also had sponsorship from IAEA and 18 non-state actors. Those are the society, international society, that have a relationship with WHO. But they were not all imaging. Networking outside of your comfort zone is extremely important. And this was supported by International Foundation Surgery, Cardiology, as well as Neurology, Rate and Technologies. We really put our network was rather wide. It was a lot of work. And then on May 24, the resolution was read by Mr. Boss from Cameroon and was unanimously accepted without any objections. So now, after we celebrated for half an hour, we realized that now the hard work really begins. And I'm very glad we are here. And the reason is that now we really need to make sure that this resolution, like a few others, and like many national cancer policies, collect dust on somebody's shelf. But I don't think with all of us working together that will happen. It will. So we now need to see how to implement. And one of the things is, as you work, and you know that better than I or better than anybody, you really need to work with every member that can help. Professional societies, because they want to implement those things on the ground, which we cannot from the United States or anyone. Health professionals, research, innovation, private sector. The private sector, government, academia, collaboration is essential, and patients. So civil society, patients are tremendously helpful, and they really care, and they are emotional and passionate about this. So we decided that we should always say perseverance, resilience, and never ever give up. So what we would like to see in the next, not 10 years, but a few years, no more than 5, that imaging diagnostics be an essential in those countries that have universal health coverage. Cancer policy are being designed or implemented. Imaging, we have to look at MRI that doesn't consume so crisis already for the workforce. We have and workforce includes education, bringing in new blood, everybody from physician, technologists, nursing, to community workers, but whatever you have in your country, we will work. So it's education, it's continuous training, it's not educate and leave, and then it's retention. from middle-income countries is a huge problem. Never ever forget research. Our field, all the fields move forward because of research, and it has to be a part of what we're doing. And these days, especially digital platforms, digital health, and AI. So to look at the African proverb, you fall down 7 times, you get up 8. I can tell you with us it was even more, 7, but we never gave up. All of you for helping us. Thank you very much.
More tenacity than any. So, you know, absolutely amazing. Do you have any questions? Yes, please.
So your last word on your slide was AI, and being able to do proper imaging requires interpretation of those imaging, and it's very hard to sort of have them in the right places. So AI may become a tool for that, but some of and if they're not well tested, people may over-rely. What are your thoughts about how do we train more people globally for responsible ways to testing before they start buying things that maybe haven't been validated?
The sound a little bit. I'll just repeat because it's a very important question, and it's a call. The global crisis in workforce that we are facing, especially, may I say, only AI is the answer. You're not we need. AI, as we train and educate, we already know implementation is digital literacy, and that affects community workers. We really rely on them very much. But there are other problems with AI. I know my field. Every part of imaging, from workflow in New York, is different than workflow in Ghana. So, to local environment and local needs. Really patience. Let's look breast cancer, because I'm looking at Beatrice and our friends. Has to as well be done for the specific populations you look at. Breast cancer in Africa starts at young age. The dense breast in Africa is an everyday occurrence, and density and the structure is different than in Caucasians. So it has to be adopted. You cannot take AI algorithms. I'm from New York, fine. So it was done in New York. You cannot apply it in China or Africa. So we have a lot of work to do, but it is exciting and it is coming, and especially in imaging, 75% of AI tool software that is approved today by FDA is all in diagnostics, which means pathology and imaging. So we think that right.
I'll be there.
Let's say one of the issues is many regulatory bodies in different countries don't allow diagnostic imaging be donated to that country. Yeah, and that can, because they need to be supported by the manufacturer and so on, that make it expensive. I get to educate the regulatory bodies from different countries key to be able to equipment for diagnosis. Because today you cannot donate a CT unless it's, sponsored for the manufacturer.
So a few years ago, there was an excellent article in the Institute, it's not Institute of Medicine, in NAM Perspectives. And the problem, the reason that happened, that so much equipment that was donated was actually dumped. It didn't work. And having us, and that's before now. It's all via digital platforms and AI. But so the machines were sitting there, didn't work. Whoever was donating, we are the reason. Resolution, we already talked to Dita because there's no time to rest. Right? And Dita promised. Dita, for those that you may not know, it's a really global organization that incorporates all the manufacturers. In our case, GE, Philips, Siemens, all of them. And they're going to look at that. So if you donate, you may need to go through Dita to make sure that equipment works and that you took care that there are people that can operate and that you took care of the maintenance for at least 5 years. It's not just giving CT. Somebody has to service, there has to be maintenance, somebody has to operate. So I think it will work now as everybody is waking up what is needed.
For example, the PACS program with the donation of Linac.
Thank you so much.
I know it's a great pleasure to introduce Patricia LaRosa from Yale, a place I know well from my past life. So it's great to see Patricia here. Patricia, a very famous trialist, an investigator, and president of the AACR. So over to you.
Thank you very much, and thank you all for everything that you're doing. So this year marks my 40th over the last 20 to 25 years being involved in workshops across many parts of the world where I teach clinical trials as a medical oncologist, knowing that many disciplines need to learn clinical trials, diagnostics we've heard of, both from a pathology as well as a radiographic or interventional as well. So when I became the president of AACR, when I was elected, you get to choose initiatives that you want. And in some of the workshops that I worked with, we were very honored and blessed to have students from parts of the world that were really low and middle income. And when I started with several of the workshops many years ago, the differential in capacity between what I had been blessed with in the United States and other parts of the world was profound. And so when Marge and the AACR asked, what would you like your initiative to be? I really only had one. Having had a few students from various countries of Africa in the many years that I taught in Europe, the workshop, I realized that we really needed to build capacity for clinical research in Africa. And so this has been my initiative, and it's taken a lot of research just to be able to move it forward. But basically, the first thing we had to do was a landscape analysis, look at a history of capacity building programs. We've all heard of PEPFAR today. We know that in Africa, there's a strong presence for European and US institutions, as well as other stakeholders. Jennifer Gent is here today with, as an example of one of those many stakeholders. And we're now beginning to see investments from some pharma, but many pharma are concerned, understandably so, because the infrastructure and the knowledge that's needed in order to bring their therapeutic trials into many countries is missing, and that data is very important when you go to regulatory agencies. So basically the first thing we did was a landscape analysis, and then we had ad hoc stakeholder meetings, and I'd like to thank people like Peter Hume and Tim Revick, and many of you that were part of those stakeholder meetings. They were advisor calls that we had brought together so that we could understand, what is it that we need to bring forward in these workshops or capacity building. And then we were able to go over to Africa. Due to some visa issues, we only went to visit one country, Kenya. But even Kenya was extremely informative in helping me. Just showing you some of the pictures from Kenya, Will had asked. We went to 3 places, University of Nairobi, 3 distinct places, 2 public, 1 private. And it was very eye-opening for a clinical trialist from the United States to go there, because they want the capacity building to do clinical research. And in talking to people, I was very honored that Will connected me with Beatrice this week. I would probably say they need clinical research. And so, I'm very, very honored to hopefully get this off the ground. So University of Nairobi, public, very different than Aga Khan University, that already has some semblance and is already doing some clinical research. And then finally we went to Kenyatta University, where, when I walked in, this young man there, who I actually invited and came to AACR, thought I was coming to talk about phase 1 clinical trials, because I'm an early trialist, but I do a lot of first-in-human studies, but that is not my intent of this program at all. This program is essentially a program that will help set 3 things. With all of the work that I've done so far in terms of my landscape analysis, ad hoc meetings, talking to researchers both in Africa as well as the United States working in Africa, it's not only about education. And when I thought about it, these are the 3 things that I think that I gained from everything that I've learned so far and that I want to move forward. What I want to move forward and what I want the organization and people who are going to help me work forward, you can give lectures every day. I mean, I remember when I went to medical school, I thought I was, a genius. I was getting all this knowledge, doing well on all these exams. But education is probably the smallest part of what we need to do to build capacity. We need sustained mentorship, and we need sustained training. Mentorship and training go hand in hand. So it's not only about getting there and doing a 1-week workshop and educating them on the various components of regulatory and consenting and patient advocacy and clinical trials and biostatistics, but it's also taking the faculty and working with the select institutions that we're hopefully going to bring forward on a prolonged basis to be able to assist them so that we can overcome a lot of the barriers. We realize that we have to select students based on both institutional as well as country readiness. Especially if you're going to bring in therapeutic trials, we have to have the regulatory agencies within those respective countries that are going to be able to help us. And institutions that are willing to put forth the infrastructure to be able to train these people and give the investigators the time that they need in order to do it well. But as I went through those 3 institutions, I realized that it's not just only training, mentoring, and educating the investigators. We need to educate cohesive and complete teams. We need to know how to put budgets together for the select phase 3 trials that they were starting to do. And that was something that I talked to them about. So can they return to an environment after we begin this training to allow them to practice their new knowledge immediately, or at least in a very short term? And we have to ensure proper preparation in continuity. In-person program bookended by online educational offering, as well as study mentorship with faculty committed to working with these sites by Zoom after the workshops, maybe on a monthly basis, to have another select face-to-face meeting so that we can ensure sustainability. And so, I'm getting pretty old, and what I want to see is at least a 5-year commitment, and that's what I'm trying to work on, so that the people that we train, the institutions that we assist in advancing this forward, can advance it to other students and other countries in the future as well. So my next steps, we're developing the program, curriculum, and application process. We're beginning to identify course directors, faculty, and mentors, and we're working closely and having multiple meetings to identify sponsors, collaborators, foundations, and hopefully funding agencies that will help bring my initiative and my dream forward. Thank you.
Thank you very much, Patricia. Amazing program you've done in your presidential time under the auspices of the AECR, so absolutely amazing. And we've got one final set of remarks in this session. It's Judy Growler, Chief Medical Officer from ASCO. You start with.
Hello, I'm Dr. Julie Graylow, Chief Medical Officer at the American Society of Clinical Oncology. I'm here to express ASCO's commitment to a global cancer fund. Cancer is a global crisis, disproportionately affecting low and middle income countries where 80% of the cancer burden lies, but only a fraction of global health spending is allocated. I don't have to tell this audience that stark differences exist in access to prevention, early detection, diagnosis, treatment, and palliative care across the globe. Limited resources, lack of trained professionals, and inadequate infrastructure are major barriers. ASCO has had a long-standing commitment to conquering cancer globally through patient care, through research and education. Our overarching vision is a world where cancer is prevented or cured and every survivor is healthy. A global cancer fund could be a critical tool to achieve that. The successes to that end, ASCO is serving in a facilitating, convening role on behalf of multiple stakeholders to further the structure of a global cancer fund. Just last week, we hosted a Global Cancer Fund stakeholder meeting in Chicago. The Global Cancer Fund is being designed to unite nations, communities, and innovators behind a common cause, to close the care gap and invest in solutions that work. The emerging design of the Global Cancer Fund is anchored in 5 guiding principles. 1, fair access. Investments must reach the most underserved by current cancer systems and markets. 2, country ownership. Solutions must be aligned with national strategies and health priorities. 3, sustainability. The fund must strengthen long-term capacity, not create parallel systems or one-off interventions. 4, integration. Cancer care must be embedded in primary health systems, digital health platforms, and universal health coverage efforts. And 5, catalytic impact. The fund should unlock co-investment, drive policy change, and create systems-level shifts, not just fund projects. A global cancer fund is not just about money, but about fostering collaboration among governments, NGOs, academic institutions, industry, and patient advocacy groups. Investing in global cancer care is a moral imperative and a smart investment in global health and economic development. We can best achieve a world free from the burden of cancer with access for every patient, every day, everywhere, through our collective effort. Please join us in making a Global Cancer Fund a reality.
many thanks to Julie there for throwing ASCO's support behind the global oncology movement. It's greatly appreciated. I think that brings us to the end of this session, so many thanks for your attention. We're going to take a 10-minute break for coffee, and we'll be back here afterwards. Thanks.
I heard you now. Well, it'll be interesting to hear it, but I feel slightly difficult. Yeah, we are connected.
You're connected
Yes.
already.
We'll be in the same session as you.
Oh, yes.
And you're working with it, so the pictures in the slides.
Yes. And so I will show the equipment
As soon as you present it like that.
Oh, are you trying to have the presentation here? No. She just wants to know about it. Internet network.
Oh, okay. Oh, okay.
Yeah, she will be able to.
Oh, okay. What email?
been talking, we're looking at, community form of like insurance, like people contributing like a monthly, not like an official structure of insurance, but like a community-based insurance scheme where we go to, the market folks, because these are people who can't afford the kind of like insurance that's currently available to support the healthcare system. So go to them. In Ghana, we call that susu, so that they can contribute like little money every month to that healthcare fund, so that when the time comes, when they need it, they can actually, afford the care and not wait for only emergency situations and not like scrambling to look for finances for their health care. And she has dealt with this a lot, especially with the number of patients that she sees at her clinic. So after we talked, we realized that given, the structure of the Ghanaian, system, that could be one of the avenues that we can explore for patients' healthcare infrastructure.
I think also maybe putting some incentives around the savings and working with, collaborating with, bigger institutions or also government or companies to match what's actually in there. That, like companies do, if you donate $5, the company is going to match $10. So that incentivizes what you're trying to do. It has impact, it has results, and I think that's something that we can do. But maybe bigger companies or government can actually think of that. What can we do to actually push that up?
Well, no. I think partly, of course, Uganda is still, I would say, in the health arena, heavily driven by the public sector. So that makes the model from the private perspective that can be implemented still more of something to be thought about. So I think what Our Excellency the Ambassador stated is very important of getting institutions like the Bank of Uganda, Ministry of Finance, to kind of think of a mechanism that can be used for harnessing the diaspora remittances so that they go directly to the people that are actually in need.
Okay, most step, I'm going to share something, okay? So, there are bonds, just like the ambassador said. There are vouchers, just as Dr. Yoka said, right? There's also insurances, as she has mentioned. And there's equity that's also out there. I just share these, right? These are structured mechanisms that offer transparency, sustainability, in order to be able to make sure that you can measure both the social and economic impact of every dollar. They are on the demand side, for example, the insurance that Dr. Yoga is talking about, and the diaspora vouchers, but we need long-term supply side too. That's where the bonds come in. That's where the equity comes in. So the question I'm going to ask, I'm going to pay Dr. Jackson, how will a Uganda bond fit into Uganda's cancer strategy?
That is a hard question. right now, cancer services in Uganda is heavily government dependent. So that means any financial instrument that is meant to directly impact on cancer care must also be channeled through the government system. The reason is that our health insurance scheme is still very much in the works. I think it is still before Parliament, before it can be passed. That would be another avenue. But as of now, the surest way is for this to go directly to the Ministry of Health or to the government of Uganda. So it kind of makes it very difficult for me to kind of give you a direct answer to that question.
Thank you very much for your input. I understood, yeah, exactly, it's a difficult question. I was thinking about it, right, and so I did mention about Sarah, the Sarah story, and I said, but how would a Ugandan bond help Sarah in her situation? Okay. I have this journey that Sarah goes through. I know you're not able to see that, but I'll just explain to you how the bond will work in the Ugandan context. Of course, you did mention the government. Yes, the government will basically manage the proceeds from Ugandan diaspora. Part of that money will be used to create a voucher that solves Sarah's immediate problem. She needs to pay for her imaging services, she needs to pay for transportation, and maybe she needs to pay for treatment later on, right? But you also have to construct a facility that will enable her to be treated, like a radiotherapy at the Uganda Cancer Institute, right? That's where the government will manage all of that, receive the proceeds, and manage that. And the investor here in the United States will get paid with the revenue generated from actually offering those services. That's what that graphic is actually showing. Is this possible?
Yes, I think it is possible, and one barrier that would actually be encountered is that in most cases, for the investigative part, the clinics or the health facilities to which most patients go to first may not necessarily have the connection to the centralized system, and they may not actually have the trust. And that may lead to, even though Sarah receives the voucher, she may not maximize the benefits that actually will give her first entry into the healthcare system. That is the only downside that maybe I can see, but otherwise, by and large, it can work. Thank you.
Okay, we would like to ask input.
Yeah, I think I'll just add a reach that gap. How do you market? How it's done, but the trust has to be built so that
the floor is open.
Thank you for the presentation. I get there to the government information, there are a lot of unclaimed funds and dormant funds. Uganda in particular have $500 million in dormant funds, that probably 20% of that can be used on healthcare. Yeah, and I guess this is for the whole group. If with access to government and to global funds, there are $800 billion in dormant funds on the world. You know, and I will mention a stupid anecdote from myself. I have a call 2 months ago. I bought a home in 2011. I paid $80K more in a closing. I didn't realize that. And basically, I didn't pick up the phone. You know, that money will be in one of these dormant funds. Therefore, I think there are a lot of money that countries using on healthcare can recoup a lot of that money. And again, the money, and we can go country by country, but it's a lot of money that can be taken from that to create a global fund.
All right, thank you for that insight. Because of time, I know this is a very substantive conversation. We are going to pick it up from here, trust me. So I want us to conclude on this note. The conversation continues because we have to stick to time, right? So I want to take the opportunity to really thank our panelists for their insights, and I also want to thank all of you for also participating here. But I think we are ready to really solve the problem of really maximizing the impact of diaspora finance in solving Africa's problems, and also the other limited, other low, middle, and income countries. So thank you so much. Well done.
All right, that was really exciting, and I think, like Catherine mentioned at the beginning, really thinking about these innovative financing approaches, and the conclusion here is that the conversation continues. But we all see a tremendous opportunity here with the diaspora, really leveraging this funding, especially at the time when global cancer funding is becoming really tough, right? So we do have, before we go for break, a little schedule change, partly because we would like to recognize one person with an award now because of the schedule change that Ambassador will have to leave earlier. So I'd like to call Lino, a very good friend, Lino Modu, who has been working with Voice of America and is the founder of VIP with Lino, to moderate a short award session for one of our honorary recipients, Dr. Corinne Jackson.
Thank you, Dr. Will. Good afternoon, everyone. Good afternoon. That's more like it. Hello, I'm Lina Hutu, and it's such an honor and my pleasure to be here with you. Given everything that we've heard and what we will hear after this, I think that it is worth giving another round of applause to all our panelists, the speakers, and really acknowledge and recognize that all of you here are making in the fight against cancer and in the global health landscape. So again, thank you. Thanks to all of you. As Dr. Will said, we will be presenting an award. As a reporter, it's important to tell stories. Dr. Robbie talked earlier about how do we improve the communication around cancer, but also to tell the stories, we have to talk about the work being conducted by researchers, experts. But one of the things that is really, I find very close to my heart is when I get to tell people's stories because of the work that they do, people that are really taking their time, dedication through their work and their passion to move
the fight against cancer forward. And I want to take a minute to say hello to Dr. Beatrice, who has been a champion in Ghana with the fight against cancer, breast cancer. Now, we will be talking about champions, about change makers, and we want to present the Distinguished Global Oncology Leader Award. We have a few people receiving the award today, and we will start today with Dr. Jackson Oram. You had an opportunity to hear him. Please. Dr. Jackson Oram is Executive Director of the Uganda Cancer Institute. Now, one of the things that the Global Health Catalyst Summit does is also inspire the next generation of global champions when it comes to health. So, part of this moment, I would like to introduce our young catalyst, Shrey. She is with the Young Catalyst medical student from the University of Vermont. Where is Shrey? She's going to join me here. Here she is. So she will take over and tell us all we need to know about Dr. Oram.
Thank you so much. Good afternoon, everyone. My name is Shrey Patel, and I am a young GHC catalyst, as well as a fourth-year medical student at the Robert Larner College of Medicine. In 2023, I have the opportunity to learn in Uganda and to be taught at the Uganda Cancer Institute. As an aspiring oncologist, it was such a privilege to learn from physicians at the Institute who embodied total dedication to the field and to working towards access to care for all Ugandans and beyond. Dr. Jackson Oram is a pioneer in embodying this spirit. In 2004, he was the only trained oncologist in a nation of 26 million and was seeing over 10,000 patients every year. He has spearheaded the creation of the East African Center of Excellence and is the executive director of the Uganda Cancer Institute today. Under his leadership, the Institute has evolved into a regional center of excellence, fostering international collaborations and building local expertise. His vision continues to powerfully shape cancer care delivery in low-resource settings. It is my great honor today to introduce Dr. Jackson Oram. Please join me in congratulating him.
Thank you so much, Shrey. And now to present this award to Dr. Oram, we would like to again invite go back here. Fighting for the health and wellness of people of Uganda. Thank you so much, Ambassador.
When I'm not on the spot, the people of Uganda. It is such a humbling experience because truly they're champions. And gaining this trust is not lost upon us. You know, for me, I'm not a career diplomat, I'm a political appointee. So when I have a mandate, and one of those mandates is to make sure that we finalize our diaspora policy. And perhaps we need to borrow a leaf from our neighbors in Kenya and have a diaspora minister. But that's a conversation beyond these doors. How proud I am. Congratulations for recognition. And what you have done is not just for today, but it is for the young ladies and she can stand here and be part of this process. We know that Uganda's future, you're a diplomat, diplomatic help. This is what diplomats do. Please get the good things in. So thank you so much, and we wish you all the best. And congratulations.
We'd like to invite Dr. Oren's wife for the photo opportunity.
Every good man is a good woman.
Where are you, young lady? GFC director.
Right, look there first.
What do you mean? I want to join you. Congratulations again, Dr. Oren.
Thank you very much, and also for the adjustment. I'm leaving for Uganda on Monday, so we just want to make sure that even with the technology, it is going to be on Uganda's evening news. But we're 8 hours ahead of you, so it gives us some leverage.
Thank you so much. So now we will continue with the program. Dr. Will?
We'll let him say a few remarks.
Yes, of course, his remarks.
Wow, this is fantastic. I'm overwhelmed. I want to first thank the organizers of the for this award and for representing the people of Uganda in this honor. I'll say a bit more, not only for myself, but for cancer patients in Uganda, my colleagues, and the government of Uganda. God bless you. Thank you.
Deserve the award. And I hope to have you on my microphone. For sure, I'm scheduling an interview right now. Take everyone for witness. Thank you so much, Dr. Oren.
All right, thanks so much, Lino. Thanks so much. Thanks so much. So we are going to go for break for lunch now. Lunch is going to be on the 4th floor. Everybody's welcome to come upstairs. Thank you. And then we'll meet back here at what time? Thanks. So we'll try to aim to get back here by 2:45. Wait, 1:45. Sorry. Thank you.